Hello. All right. Well, looks like we got ourselves a nice cold day where we get to stay inside and stay bundled up. So here is Module 3. Okay, so today we're talking about interviewing the health history. And then I'm also asking that you please read Chapter 4. It's called Nutrition and Measurements in Math. The nutrition and measurement section should be a review from your nutrition class, hopefully. But again, just to kind of help pull in the nursing pieces that you may or may not have gotten in your nutrition class, that's a good way to review. Okay, so we're going to start off with interviewing. We're going to talk about how interviewing really gives us a baseline understanding of our patient. It helps us to know a little bit about them, who they are, okay, where they're coming from, what motivates them, okay, where do they find their meaning, okay, what makes them scared, okay. I had a patient who came in the other day and literally there was nothing for me to physically assess of this patient, but part of my interviewing process with her was to figure out what her concerns and fears were and what was, causing her to feel the way she was feeling. Okay, so that interviewing really gives us the opportunity to talk with our patients and understand where they're coming from, where they're going, what their fears are, and who they are. Okay, I'm hoping that you've already talked about this a little bit in Dr. Crowther's class, but we're going to talk a little bit about the HIPAA. This is the Health Insurance Portability and Accountability Act. It's a law that determines really what we can and cannot share about our patients. Okay, who we share with and what we share depends on the person we're sharing it with. Okay, so as a nurse taking care of a patient, okay, if I'm giving a report to the oncoming nurse, I can share anything that is relevant to that patient's care with that nurse. Okay, I can also share that same information with a physician. Okay, I cannot, however, share the same information with the family. Okay, because the family is not relevant to their care unless their family member is their primary medical power of attorney and the patient does not have the ability to make their own decisions. Then the family can be informed of all of that. Okay, so things that we might share with another nurse, we might share the medical diagnosis, any lab values, any assessment findings, any concerns that we have. That sort of information will be shared with nurses. It can also be shared with their provider. Okay, so information that we share with the family member would only include information that the patient specifically has given us permission to share. Okay, so if the patient doesn't want their family member to know the information, then they don't get to know the information. Okay. We also can share a little bit of baseline information with transport. Basically, the only thing that transport needs to know for their transport is what is relevant to the patient and what is likely to happen to them en route. So we might share with the transporters, this patient is on 2 liters of oxygen. They need to stay with the head of their bed elevated. The patient needs to wear a mask, things like that. You wouldn't necessarily tell the transporter, my patient has the flu, they're having trouble breathing on room air, so we put them on oxygen. It's just simply going to be keep the head of the bed elevated, keep the mask on the patient, and then give them some oxygen on the way. So when we talk about therapeutic communication, I want you guys to stop and kind of think about how we communicate as people. Okay, we communicate and there's a lot of different people in the world. There's the type of people who, if it's on the mind, it's out the mouth. Okay, and that's a normal form of communication. Therapeutic communication basically means that we are looking to have a connection with the patient, but we're looking for their side of it. Okay, we don't want to, how do I want to say this? We don't want to share a lot about ourselves because the focus should be on the patient and how the patient is going to feel better. So when we talk about therapeutic communication, we talk about things like kindness and compassion and warmth and patient-focused, okay? This is a mnemonic that your textbook offers up for you. It's called clear communication. When you're talking with people, center yourself and kind of focus. Remember that sometimes it's not always as easy as we think to listen and hear people. Okay, so when you're more mindful of who you are in the situation that you're in, you really can listen and hear what they are saying. When we talk about empathy, okay, empathy is not understanding, but hearing and feeling where the patient is coming from without taking the weight on yourself. Okay, so empathy is very different than, I'm going to lose the word now. Okay, but empathy is, listening and hearing what's going on with the patient and kind of hearing where they're coming from and understanding, not necessarily knowing and saying, I know what it feels like, but more the standpoint of how we, how we convey compassion and kindness. Okay, be very present and fully focus. Okay, we all have had people that we've talked to and we know the focus isn't quite there. With patients, it's very important that we listen and hear everything that they're saying. Respect is probably the number one thing where I see healthcare providers go wrong when we talk about our communication. Okay, healthcare providers, as they tend to get a little bit more experienced and farther down the line, tend to lose a little bit of the respect for people. They don't always do that, and I think it's very important that we remember to respect the individuals. Okay, so when we talk about preparation for the interview, if you have a patient chart, that's always a great place to start. Okay, is it an absolute requisite? No, but it's a good place. Okay, please make sure to arrange for an appropriate interview setting. Okay, when we talk about lighting, we don't want it to be dim or dark because that makes people sleepy. Okay, the average distance that we really should have our communications with our patient is somewhere in the area of 3 to 4 feet. That seems to be the comfortable area for patients. Okay, ensure their comfort, but again, we don't want them snuggled down into the covers, being all nice and snuggly. Because that's going to increase their comfort and it's also going to make them kind of sleepy. So you have to put them in a good position for learning and interviewing and talking with them. Do try to minimize noise, turn off the TV, okay? Ask any relevant people to leave the room if you need to, because again, remember that HIPAA, by talking to a patient with their family member in the room, you are at potential for violation of HIPAA. Okay, be sure to allow the appropriate amount of time. Okay, time is very important. Okay, you don't want to make them feel rushed the best you can, so do take that time to work with them. Okay, we want to know who the patient is. Do we have permission to carry on with anybody in the room? Okay, so I had a patient on Saturday who was I assumed it was a spouse. It wasn't a spouse. It was a brother who came in with the patient. Okay, and we did not have permission to talk with the brother in the room, and so we at that point asked him to step out so that we could interview the patient. Okay, when we begin our introduction, we want to introduce ourselves, and I'm going to kind of back up just a little bit because you see, part of the introduction is shaking hands. When you do this, please make sure you wash your hands before you touch your patient. Okay, that little handshake, while some people find it meaningful, some people don't. So if someone does not reach out and shake your hand, please do not take offense. But wash your hands, introduce yourself, offer your hand. You can tell a lot by shaking someone's hand. Do they have a nice, firm, strong grip, or is it weak? Are they clammy? Are their hands sweaty? What sort of information are you able to get there from that? Are their hands cold? Okay. Always encourage the patient to ask questions. So when they have a moment and they have a question and you see that they're looking a little confused, ask them, what's your question? How can I help you? Okay. Be sure to use language that the patient and the family understand. So if they don't know what hypertension is, maybe you need to take it a step back and talk about, do you have high blood pressure, or do you take any medicines for your blood pressure? A lot of people will assume that because of the fact that they're on medications for blood pressure that they don't actually have it. Okay, make sure we provide any necessary privacy. Most hospital systems now are trying to get to the single room occupancy, but do keep in mind that the best you can do to ensure privacy in a dual occupancy room is to pull the curtain and speak quietly. Okay. Smile and nod when appropriate. Let your patients know that you're listening to them. Okay. Don't look like the bobble-headed doll, but smile and nod when it's appropriate. This is, I think, another very hard part for nurses. We need to ask one question at a time and then wait for the response. Okay, it takes time to let them kind of think about the answer and then time to give it back to you. If you're rapid firing questions at them, they're not able to keep up. They're going to end up confused and frustrated and, potentially angry. So don't interrupt them. Okay, don't try to take excessive notes. Okay, it works better to just have that dialogue, that front experience with them, okay, face to face. Don't try and be scribbling notes, because that disrupts the eye contact and it disrupts the connection that we have with the patient. Please always ask permission before touching your patient if you're going to do something that involves touching them. Okay, so when we address our patients, how do we address them? There's a lot of different names that we can possibly address them by, okay? One of the things that I do first when I introduce myself to my patient is my name is Amy. I'll be the nurse taking care of you. Can you tell me your name and date of birth today? Okay, they tell me their name and date of birth, and then I ask them, how would you like me to address you? Okay, because some people will like to be called Mr. or Ms. Some people will like to be called Doctor. Some people will like to be called by their first name. Some people prefer their last name. Okay, always ask your patient how they want to be addressed. Okay, my friend talks about one day when he went into the doctor's office, and the doctor sat down and said, "Hi, Michael, how you doing?" And he said, "Oh, hi, Bob, how are you doing?" And the doctor got really offended. And Michael said, "Why are you offended? I thought that we were on a casual first name basis," because Michael had a doctorate as well as the doctor. So figuring out how they want to be addressed, if the doctor wanted to be Dr. So-and-so, then maybe Michael wanted to be Dr. last name. Okay, so think about how you're addressing them, how they want to be called. Okay, my middle child is a prime example of this. Their given name is Samantha Jackson. However, they go by Simi, okay, or by Jackson. So ask them what they want to go by, okay. Please look up the definitions, okay. So when we talk about active listening and observing, okay, this is, we want to hear and process what's going on. Active listening requires us to pay attention. We talk about broad open questions, okay? A broad open question is, how are you today? Or what is bringing you in today, okay? There are these wide open-ended answers that any number of people can come up with a bunch of different answers for. Clarification involves asking for something to be clarified. Okay, thank you so much for telling me that you're having this abdominal pain. Could you please clarify where in your abdomen you're feeling it? Or what do you mean by the fact that you feel like you're dizzy? Is it like a room spinning dizziness, or is it a lightheaded sort of sensation? Okay. Confrontation is when we're seeing things that are not matching up with what the patient is telling us. Okay, so last week we talked about my patient who is sitting in front of me eating a Big Mac and telling me that their pain is a 50 out of 10. Okay, so confrontation might involve telling the patient, I see that you're telling me that your pain is a 50 out of 10. However, I see you sitting here eating a Big Mac and drinking a pop. Can you tell me a little bit more about why it is that you're doing that? Okay, we want to demonstrate empathy. We talked about that already, as well as respect. Exploring is kind of an area where you will perfect as you move through your nursing practice. It kind of helps us to delve a little deeper into the situation. Okay, as a new nursing student, you're not always going to know the right questions to ask to figure out exactly where you want to guide the interview and what sort of questions you want to do. But exploring helps us to understand more what's going on and what led to it. Okay, so if we have a patient who comes in with abdominal pain, okay, one of the first questions I'm going to ask is, when did the pain start? Okay, where in your abdomen is it? How long has it been going on? Describe the pain. Okay, all of these things are little exploring communication techniques. Facilitation is kind of augmenting patients, and we talked about with the pain assessment the other day about giving them options. How do you describe your pain? Is it aching, stabbing, throbbing, sharp, shooting, anything like that? This is facilitation. Focusing is one that we use a lot when we have patients who kind of do what we call the derailment or the side tracking. Okay, we have to bring them back to the area of focus. Okay, so sometimes it's, okay, hold on just a sec, we were talking about this area, let's go back to this, and then we'll move on to what you want to talk about next. Reflecting or stating the observed. This is something like, you tell me that you don't have any pain, but when I push on your abdomen here, I see that you're wincing. Okay. Transitional statements, an example of that is, okay, thank you so much. Now we've finished talking about your medical history. Now I would like to move on and talk about your surgical history. Okay. Silence is the hardest thing for many, many people to employ. Sometimes that uncomfortable silence isn't just enough for that patient to come out with something that's going to be really important for your interview. So take the time to be silent and listen, and even if it's uncomfortable for you, keep going with it because it's important. Okay. Summarizing is just giving a summary of what you heard throughout the interview and asking, do I have all of this information correct? Or is there something else you'd like to add? Some barriers that we have to therapeutic communication. Leading the patient. Okay, asking a patient a question that you put in a negative tone is not going to help anything. Okay, so the best example of this is asking your patient, "You don't smoke, do you?" Okay, because we're leading the patient down the road that no, we really want them to say that no, they don't smoke. Okay, another barrier is asking too many questions, and again, not allowing enough time for response. Rapid fire questions on a scale of 0 to 10. How do you rate your pain? Where is your pain at? Describe your pain. Is it aching, stabbing, throbbing, sharp, shooting? Da, 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 da. Okay, give them time for that response. Try not to use the medical jargon. Okay, so that's hypertension, coronary artery disease. Okay, they don't always understand. Okay, please do not assume that you know what the patient is saying. Do not assume that you know the situation that they're in. Okay, stop and think about it. Do not take patients' responses seriously or personally. Sometimes when people don't feel good, their responses are not as nice and as kind as they normally would be. You have to separate yourself and say, oh, okay, this is not really truly what they're trying to do right now. Don't take it personally. Again, there are moments where if your patient is being argumentative or rude or having issues with you, it is totally okay to say, hey, you know what? You're not being very nice right now. I'd like to continue being nice to you. So let's figure out how we can make this happen to be a mutually agreeable relationship. Okay. We don't ask specifically why questions. Okay. Am I saying that every time that you want to use the word why is inappropriate? No. There are times where why might be appropriate. Okay, times that it's not appropriate. Why didn't you take the Motrin before you came in? Why did you do this? Why did you do that? Okay. Sometimes it is okay to have someone explain to me how you chose this instead of why did you do this? Explain to me how you chose it. Why puts a negative connotation on it and it makes people a little bit defensive. Please do not offer false reassurances. Oh, you're okay. You're going to be fine. You're here. You're not going to die. Okay. You don't know that patient isn't going to die, and to them that fear is really real. So we do not offer false reassurance to them. Try not to change the topic until the patient is actually ready to, the best you can. Okay. Giving an opinion. Don't give an opinion of your own because you really have no idea what it's like to be in their circumstances. You have absolutely no idea what it's like to walk a mile in their shoes. So when they ask you for an opinion, my answer is, I'm so sorry, I can't give you my opinion because I'm not in your situation. I don't fully understand what's going on. Okay, so Give them that opportunity, okay, to make their own decision. You can give them all the education in the world that you want. You can give them all the resources. But helping them to understand is very different than telling them what you would do, because you don't know what you would do in that situation. Okay. Don't stereotype. Okay. You have the patient sitting in front of you that is probably demonstrating some poor hygiene, or they have multiple piercings or tattoos or something else that makes them different than you. Please do not stereotype them. Some of the nicest people that you will meet are some of the people that you would not assume. So don't cluster people into a bucket without knowing who they are. And patronizing language, this is the example of dear, sweetie, honey, anything like that, okay? Until you're called that, you really don't realize how offensive it is. It's much nicer to use the name, and you know, if you don't know what to call someone, don't use their name, okay? Just say, excuse me, or please, or could you do this, okay? No patronizing language. Well, I was hoping to do some role play here, but we'll skip that for now. So when we talk about hearing impaired patients, a lot of the hearing impaired patients do very well with written language. Okay, so you can give them a notepad and a pen, and you can write, they can write. Okay, it works very well. There are word boards as well that have like pictures and images on them. So when you look at you know, there might be a picture of a toilet, there might be a picture of something to drink, something to eat, a shower, there might be all these different things, and they can just point to the picture of what it is that they need. Okay, a lot of facilities now offer translation services via an iPad. So you take the iPad in and you place it in front of the patient. The translator is on the phone, okay, or on the iPad, and you can see their face. And what this does is it allows the patient to interact with an American Sign Language translator, and the translator can hear you and what you're saying and give the information back to you. Okay, so with our translation services, we have to be very careful that we ask one question at a time, wait for the response, and then give another question. Okay, our visually impaired patients, please don't fall under this false pretense that visually impaired patients are deaf. They are not. They can't see, so you can still talk to them in a normal language and a normal voice, but we do have to explain to them, you know, hi, my name is Amy, I'm the nurse taking care of you today. I'm going to be standing about 2 feet from you, is that okay? Also tell them, you know, your call bell is by your right hand, your table is on the left hand side, I have your telephone close to you. Okay, so give them that information when we talk to them and explain to them if they can't see. Our aphasic patients, these are patients who cannot talk. Okay, sometimes patients who can't talk are actually able to write. So sometimes it's a good idea just to give them that little piece of paper so that they can write things out. The other thing you can do is give them that visual board as well, and they can look and point to whatever it is that they need to do. Cognitively impaired patients, a lot of times you have to give the directions multiple times. You have to maintain the patience, okay? Be very kind and give them time to respond, okay? Our aggressive or challenging patients, that's always a great opportunity to say, you know what, I'm sorry, I'll come back when you've calmed down a little bit, and that's totally okay. Our challenging patients, we just have to find a little bit of patience and work through them, okay? Language barrier, this is the same thing as with our hearing impaired patients. When we use a translation services, we always have to use a translation service for our language barrier patients. Ask one question at a time. Let them ask the patient. Wait for the patient to respond. Wait for the translator to respond to you. Okay? Again, ask another question. Translator relays it to the patient. Patient relays it to the translator. Translator relays it to us. Is it okay to use a family member as a translator? No, it's really not. Okay, in a medical emergency, if I have a patient who's going to die right now, yes, I will use their family member as a translator. If it is anything less than the patient is dying, I am required by law to go and get some sort of translation service for the patient and document that in the chart. So a lot of the translation services will have a translator number. They will tell you, hi, thank you. You've reached translator number 46532. My name is George. I'll be translating Spanish for you today. And then you record that number in the patient's chart so that they understand how we got the information. Our low health literacy patients, you have to remember that the average American needs health information presented at a 4th to 5th grade reading level. Okay, so you think about what you read in 4th and 5th grade versus what you read now, which is probably somewhere in the area of a 13th or 14th grade level. Okay, so remember that we have to step our language back and use simple, clear language for them. When we talk about our respect or our cultural considerations, keep in mind that different cultures have different preferences in terms of their modesty and in terms of their care providers and anything like that. Remember that distance is very different among populations, okay? Americans were really good with this 3 to 4 feet. You start stepping closer to 3 to 4 feet on an American, it's almost disconcerting to people. They will step back, they get a little uncomfortable, they kind of look at you, okay? However, in Europe, it's very common to stand within a foot or two to talk to someone, okay? So just make sure that you know that there are varying distances, and if someone looks uncomfortable, step back. Okay. Cultures have varying levels of touch. One touch is appropriate. Some will hold, or some will shake your hands. Some will not. Some will not want to touch you. Some just want to be touched with a stethoscope. That's fine. Okay. Think about different languages, or different cultures have different volumes of speech. So our Italian population and some of our Islamic cultures have very loud speech. Others are very quiet and very soft-spoken, okay? So keep in mind how you're approaching them, okay? You don't need to get louder. If they're getting louder, you can still speak in a normal tone of voice, okay? Some people have a very specific response in terms of the length of time, okay? Other things, like some cultures, you want to go in and you literally want to talk about, hi, how are you feeling? Oh, it's a beautiful day. You want to make some conversation. You want to make that connection before you try to get right into it. Other cultures are very much, okay, you're here. What do you want to do? And then you can leave me alone. Okay, so just know that there are some variations based on that. Our Islamic cultures, many of them have restrictions in terms of bare skin and who can see the bare skin. Usually it's the female patients who have limitations in terms of who can see their bare skin, and literally it goes to their forearms, okay? I had a patient, so just keep in mind, sometimes they need more covering. Make sure to provide any privacy and modesty that you need. Okay, here's some examples for you. Okay, our American Indians and Alaskan Natives tend to prefer same-sex providers. Okay, Asians will divert eye contact as a sign of respect. Okay, but in Western cultures, the lack of eye contact is a sign of disrespect. So keep in mind that different cultures have different ways of doing it. Okay. Okay, so we talk about open-ended questions. Open-ended questions are these really big questions that literally anything can be responded to, okay? My favorite example of an open-ended response is, so tell me what's bringing you in today? Or how are you feeling? Okay, these are great open-ended responses. Questions. Closed questions are usually 1 or 2 answers, yes or no. We ask the pain scale on a scale of 0 being no pain, 10 being the worst. How bad is your pain right now? When they give you a number, that is a closed-ended question. It is a very limited response. Okay, so we're going to start with our open-ended questions, and we're going to end with our closed questions. Okay, so start really large, and then you're going to we talk about a funnel. Okay, so we talk with our open-ended questions and our closed-ended questions here. And it helps us to truly understand what's going on with the patient. And as you're working down through here, you as the nurse are creating the focus of the interview. Okay? Okay, so phases of the interview. We have our introductory phase, our working phase, and our summarization phase. Okay, so our introduction phase is, hi, my name's Amy. I'll be the nurse taking care of you today. I'd like to conduct a health assessment on you. That involves me asking some questions, talking with you. Is there any questions that you have, and do I have your permission to begin? Okay, the working phase allows us to the working phase is when we start asking the questions of the interview. Okay, so what's bringing you in today? Tell me about your history of the present illness. What's going on? Tell me about your medical problems. Tell me your surgical history. All of these pieces, that falls under the working phase. Summarization is when you're getting ready to wrap things up. Thank you, Beth, so much for speaking to me about your health history today. I appreciate that you took the time. I hear that, these are your concerns, and this is what you would like to work on as we move forward. Okay? So when we talk about subjective and objective, okay, our subjective comes from the subject. Okay? And the subject is the patient. Ooh. Okay, so when we talk about subjective, this is usually symptoms. Okay, so this is things that we as the nurse cannot see, right? So examples of this, we have nausea. Okay, we might be able to see our patient looking a little green around the gills, okay, when they kind of look like they're about to vomit on you. But another example is our dizziness. Okay, pain is subjective, right? We can't really see a lot of outward signs of it. Objective is the patient becomes the object. Okay, so these are items that we can see and judge, right? Sorry, my handwriting is so awful on the screen here. Nurse can see, smell, touch, and evaluate, right? So our examples of this are wheezing in the lungs, a heart murmur, okay, edema of the lower extremities. All of these are objective findings. Okay, so objective, the patient becomes the object. Subjective, the information comes from the subject. Okay, so when we talk about our health history, it gives us some sort of background on the patient. It helps us to know exactly what's gone on with them. Collecting a true health history really takes a lot of time. It takes probably upwards of half hour, 45 minutes to do it. Okay. It also looks to obtain information about the patient's personal beliefs about health and wellness. Is it important to them? Do they exercise regularly? Do they think it... oh, sorry, guys. How do they reflect on that? Do they eat well? Do they not eat well? Okay. A review of systems literally goes through every single system of the body and asks the patients 2 or 3 pertinent questions about that system. Okay, so we talk about a review of systems for general. Okay, have you had any weight loss? Any changes in your appetite? Any hair loss? Okay, those are all general findings. Okay. Review of system questions for the lungs. Do you have a cough? Do you ever notice you're wheezing? Do you have any difficulty breathing? Those are all review of system questions. Your textbook has a really nice list of them, so take some time to look through that. Pertinent positives are things that are positive to their current complaint that are relative to what's going on. Okay, so if you were asking questions about shortness of breath and your patient had pneumonia, a pertinent positive would be shortness of breath. Okay, a pertinent negative would be they don't have the shortness of breath when they're being evaluated. Okay. Primary data sources are the patient themselves. Okay, a secondary data source would be either a family member or a medical record from a nursing home, somewhere else where we're getting the information other than the patient. We always have to talk about the reliability of the source. Is it, is the patient alert and oriented ×4? Are they able to answer questions appropriately? Just to remind you, ANO ×4 is alert and oriented to person, place, time, and situation. Okay. If your patient can answer all 4 of these, they're likely to be a reliable source. Okay. Likely. Not always, but likely to be a reliable source. Okay. Types of health histories that we need to talk about. We have our comprehensive. This is literally from the day they are born through the present. Okay. So for me, that would be from February 7, 1975, all the way to, and today is Monday the 28th, January 28, 2019. Okay. So literally, this includes everything from the fact that I was a vaginal birth, I had chickenpox as a kid, okay, I've had 3 babies, all of which are alive, all of those things go under the comprehensive sort of assessment, okay? Our focused or problem-based health history is just relevant to what's going on right now, and that is if your patient has chest pain, our health history is going to be related only to the chest pain, okay? So we're going to want to know if they have any prior history, HX is history, by the way, of any heart problems. Okay, heart problems. We want to know if they have any shortness of breath. That's SOB is shortness of breath. We want to know if they have any nausea. Okay, we want to know if they have any history of high cholesterol. We want to know if they have any irregular heart rhythms. Okay. Okay, all of these pieces fall under the type of health history. A follow-up is when they're coming in for reevaluation of something that they have already been evaluated for. Okay, so our patients who are evaluated in the ER for chest pain might go back to their primary care provider's office for their reevaluation. Okay, so it's not always the person who collects the initial information that does the follow-up history. Okay, so when we take our health history, it is documented in the charting. Okay, it contains a family history. So family history, we generally go back to the grandparents. Okay, first generation grandparents, we include the parents and we include any offspring. So most of y'all, I'm assuming, don't have children right now. I know a few of you do. If you do, your children's health history goes in your family history if they have any medical problems. Okay, my son has asthma, therefore it's delineated in my family health history that I have a son with asthma. Okay, we also put in their psychosocial factors. Okay, what else is going on in their life that influences their health and well-being? How do they care for themselves? Do they exercise? Do they take showers? Do they eat right? What are the strengths and weaknesses of the patient? Are they very headstrong and just determined that they're not going to diet, they're not going to exercise, or are they really open to change and doing what's right and working to improve their overall health needs? Okay, what are their health needs? What do we need to teach them? Okay, do they not understand their diabetes? Do they not understand cholesterol diet? What do they need information on? We have to look at what their discharge needs are or their case management referrals, and that's for discharge from the hospital. Okay. Our components of the health history is their reason for seeking care, so why they came to the hospital. Okay, I came to the hospital because I have cancer and I needed my chemo treatment. Okay, history of present illness. I was diagnosed with cancer 6 months ago. I'm undergoing treatment. That's our history of present illness. Biographical data includes name, birth date, gender, our living arrangements, all of that falls in there. Allergies. We want to know not only what they're allergic to, but what their reaction is to the medication. Okay. Are they just going to get nauseous if we give them the medication, or is it literally they can go into full-blown anaphylaxis and die from a medication? Okay. Want to know what their current medications are? Are they on blood pressure medications? Are they on water pills? What sort of medications are they on? Are they up to date on their immunizations? Okay. Have they had their flu shot this year? Have they had a pneumonia vaccine? All of those pieces. Are they up to date on their childhood illness or childhood vaccinations? Do we have, I'm so sorry, guys. Parents who are not vaccinating their children now, and so we have to start looking at that to try and figure out, what sort of diseases are they at risk for. We look at their health prevention and promotion. Do they get their mammograms like they're supposed to? Anything like that. What is their medical history? Do they have heart problems or lung problems, or, have they had a surgical history where we've had surgery on their belly? Mental health history includes anxiety, depression, schizophrenia, PTSD, any one of the mental health concerns. We do need to make sure that that is included in the health history, because that really will impact a lot of what goes on with their physical well-being. We do also do an abuse screening for violence, neglect, or abuse. Okay. We do a functional assessment. Okay. So we have our ADLs, or our activities of daily living. We want to know ambulation or bathing, ambulation, toileting, transfers, eating, and dressing. These are all things that they should be able to do on their own. These are the 6 ADLs. Okay. Our IADLs, or independent activities of daily living, are shopping, housekeeping, and driving. These are basically things that they need to do to be able to live on their own. Okay, they need to be able to get their meals, they need to be able to cook and provide for their shopping. Our cultural assessment is part of every assessment as well. What are their beliefs? Okay, do we have to get in, to the nitty-gritty to find out exactly what it is? No. We do have to have a general idea and how it impacts the health of the population. What are their cultural norms? Okay, what language do they speak? What do they believe caused the problem? There are cultures who believe that diseases are cold diseases and there's warm diseases, and you treat them with the opposite. Do they believe that their disease is the result of mal de ojo, a bad eye, or the evil eye? All of these can play into their aspects of health and wellness. The decision maker in the family in a lot of cultures is the matriarch, or the mother of the family. There are patriarchal societies where the oldest male makes the decisions for the family. Okay, or is it literally the patient who's sitting in front of you? Okay, do the different cultures use traditional practices of medicine, or do they use non-traditional? So do they use Reiki or acupuncture or cupping? What other sort of health practices do they engage in? And I always like to ask about different cultures, is there something that I should know about your care? Okay, what is it that I need to know? Okay, spiritual assessment. This is, I think, a little bit deeper than nurses tend to go a lot of times. Not saying that it's not important. I think it's very important, and we do need to go there. I think this is one area where we as nurses tend to lack. Okay, what are their beliefs? Are they spiritual or are they religious? Okay, they're not the same thing. Okay, when we talk about religion versus spirituality, religion is going to church, a faith in a higher being. Spirituality is more where they find their meaning. Where do they find their solace? Is it out walking in the parks? Is it meditating? Is it sitting in a church service on a Sunday morning? Anything like that, okay? How do they address loss? Okay, think about how people respond in the loss of someone or something that they love. Okay, how do they address it? Do they believe that that person that is lost has gone to heaven, or do they believe that their spirit has entered the universe? What do they believe of the loss? Please know the FICA model on page 33. Okay. For our mental health assessment, we look at the overall general appearance of the patient. Are they clean? Are they well groomed? Are they logically making sense? Okay. What is their emotional reaction? Okay. Look at their speech pattern. Okay. Is it clear? Does it make sense? How loud are they? How well are they using their words? Are they slurring? Okay. We look at their memory and cognition. So if you ask or introduce yourself and they forget your name within 5 minutes, okay, that might be a concern to you. What is their orientation? Again, that's alert and oriented times what? We have our behavior and mood. Are they normal? Are they just a little off, or are they bouncing off of the walls? What are you looking at there in terms of that? All right, guys, that is our reference here for chapters 2 and 3, and remember, you're going to do chapter 4 on your own. Okay, so now we're getting into some math. Okay, so a few pointers before we start to get into math. First and foremost, always double check your math. Always, always, always. Okay, and include the units of measure. Okay, so if I'm asking you for milliliters, please make sure that you give me milliliters. Ask yourself if the answer makes sense. Okay, if I'm telling you that your patient has a temperature of 39.4 degrees centigrade, and you tell me that the answer is, and I'm asking you what that is in Fahrenheit, and you give me an answer of over 2,000, it doesn't make any sense, right? Your patient shouldn't have a temperature of over 2,000 degrees, okay? All answers need to be listed to the 10th position. Please show your work and always use a calculator. It just helps to reduce the errors like this one. Okay, so let's see. Let's get into a Word document here. Actually, let's get into all right. So let's work on some math. All right. So what you see up here is all of our, excuse me, let me see if I can make this a little bigger. All of our calculations that we need, okay? So what we're going to do here. So we have 220 pounds. We're looking at number 1. 220 pounds, okay? So we know that, and we're looking for kilograms. So we have 1 kilogram equals 2.2 pounds. So what we're going to do here is we have 2.2 pounds equals 1 kilogram. So the easiest way to do this is 220 pounds divided by 1 kilogram. Or I'm sorry, excuse me. We have 220 pounds, right? And we know that 2.2 pounds equals 1 kilogram, so we're going to divide by 2.2 pounds, okay, in order to get our kilograms, okay? And what do you guys get? I get 100 kilograms. Is that what you guys got? I hope so, because that's the right answer. Okay. Moving on to the next one. We have 10 kilograms, okay, and this time we're going 2 pounds, okay? So if we go up here and we're looking at 1 kilogram equals 2.2 pounds, we have 10 kilograms times 2.2, that's our 2.2 pounds, right? And we're going to get 22 pounds, right? Okay, so this is obviously a pediatric patient. Okay, everybody good there? Okay, I have 10 kilograms. 1 kilogram equals 2.2 pounds. Okay, so I get 2.2 pounds. Or 22 pounds, excuse me. All right. Okay, so we have 52 inches equals how many feet? Okay, so you're going to have to do a little remembering here. How many feet are in an inch, or how many feet are, or how many inches are in a foot? Okay, 12 inches in a foot, right? Remember that? Okay, so what we have to do is we take 52 inches and we divide it by 12. Okay, and you get 4.33 feet. Do we really ever say that people are 4.33 feet? No. Okay, we say that they're 4 foot. And what's a third of 4 foot? 4 foot 4 inches. Okay. So now what I'm asking here is 52 inches is how many centimeters, okay? So our centimeters, up here we have 1 inch equals 2.54 centimeters. Okay, I'm just going to bring this down here for you. Okay, so 52 inches equals 254 centimeters. So we have 52 inches times 2.54 cm. You get 132.08 centimeters. Okay, makes sense how we got there? 1 inch equals 2.54 centimeters. We take our 52 inches times 2.54 centimeters and we get 132.08, and cm is here. Okay, so here's my units. Remember I told you though I want you to list this only to the 10th. So the answer truly for this one is going to be 132.1 because this will round up. This is your 10th position here. Okay. 52 inches equals how many meters? Okay, so this is an easy one. Okay, so we have 52 inches, which we know is 132.1 centimeters, right? So all we're simply going to do is move the decimal over 2 places and we get 1.32 meters. Okay. Everybody, if you don't remember your meters and your kilometers and your millimeters and your cm, I'll see if I can post this for you under a separate thing. Okay. Now, if we have a patient who's 5'2", okay, so we have to take our 5 feet times 12 inches, right? And that's 60 inches. We add another 2 from this 2 here. This is where a lot of people go astray. Okay. we get 62 inches. And we multiply that by 2.54, right? Because this is the same formula that we used up here. And we get a total of 157.48. Taking that to the 10th position, we're going to get 157.5. See how we got there? Okay. Oh, and look, here's another easy one for us. If we have our patient who is 157.5 centimeters and we want to get to meters, 157 cm, we're going to take it, we're going to move that decimal over 2 places, we get 1.57 meters, and then it becomes 1.6 meters. Oops, 0.6 meters. That makes sense? Okay, our 182.8 centimeters. How did we get here? Okay, well, we have to divide by 2.54, right? Because we know that the 2.54 is how many centimeters are in an inch. And we come up with 71.96, so we're just going to give this a 72 inches, okay? 72 inches divided by 12 inches, right? So we get our feet. And look at that, our patient is exactly 6 feet 0 inches, right? Make sense? All right, so which number signifies the 10th position? This one, 6, right? So if we have to round this number, it's going to be 2.31.65 would take us up to 7, okay? So when we record this out, your answer is going to be 231.7. Everybody good there? Okay. If you're not, please let me know. Okay, guys, math is really important. A lot of people who went down on my final exam last semester went down on the math. So make sure that you understand it because it's really important when we start to calculate drugs. Okay, so we have 98.6 degrees Fahrenheit equals how many degrees centigrade? Okay, so we are given Fahrenheit, okay? So we want to take Fahrenheit minus 32 times 5 over 9. So we have Fahrenheit minus 32 times 5 over 9, okay? And this is how we get centigrade. So we have 98.6 degrees minus 32. Okay. 98.6 minus 32 equals 66.6. Okay, so that's our answer here. 5 over 9, I know, because I've done this enough times, is 0.55. If you want to divide it out, you just simply divide 5 by 9 and you'll get proof that it's 0.55. Okay. So I'm going to take and I'm going to multiply 66.6 times 0.55, and I'm going to get 36.6 degrees centigrade. Okay? Everybody see how I got there? Okay, this is my Fahrenheit here. I'm subtracting 32. My 5/9 is the 0.55, which comes down here. I get 36.6 degrees. Okay. For our centigrade, we have Celsius times 9/5 plus 32. So Celsius plus 9/5 plus 32. Okay, so centigrade is 39 degrees. I'm going to tell you this 9/5 I know is 1.8. Okay, you can work out the math there if you want to do it. Okay, plus 1.8 plus 32. Okay, Just want to double check my math. Yes. Oh, this is times. Sorry, not plus, times. Okay, so we have 39 times 1.8 equals 70.02 plus 32 equals 102.2. 102.2 degrees Fahrenheit. 102.2 degrees Fahrenheit. Okay, everybody good how we got there? Let's do that one again just because I'm a little nervous here and that because I wasn't 100% clear. Let's do that one again. Okay, so we have our 39 degrees Celsius. We have our centigrade times 9/5 plus 32. So our centigrade is 39 degrees times 9/5 equals 1.8 plus 32. Okay, 39 times 1.8 equals 70.2 plus 32, and that gives us 102.2 degrees. Okay. Okay, so for our radial pulse minus our pulse deficit, we're going to take our apical. I'm going to show you where it is up here. Pulse deficit is our apical minus our radial. And when we talk about this, this is just what happens when we have heartbeats that are lost between the heart and the periphery. Okay, so if we have the heart that's beating at an apical rate of 66 beats per minute, and only 62 of them are getting to the wrist, okay, which is where the radial pulse is, right? Okay, we just take 66 minus 62, and we have a pulse deficit of 4 beats per minute. Okay, does that make sense? We're just taking the apical heart rate, which is the heart rate. Let's see if we have a little person here. Okay, their apical heart rate here is 66. By the time it makes it to their arm, we've lost 4 in between. Does that make sense? Okay. All right. Pulse pressure. Okay. Pulse pressure is the systolic minus the diastolic blood pressure. Okay, so remember from last week, our systolic is our top number, our diastolic is our bottom number. Okay, so in this case, we are simply going to subtract 120 minus 80 equals 40, and 40 is our pulse pressure. Okay, so on this problem, we have 190 minus 60, and this is 130. Everybody good there? Okay, so 90 over 74. Okay, there you go. Email me your answer when you've watched the video. This is how you'll get class attendance for the day. All right. This is a little bit of a complex one, so I hope you guys are all ready for this. Okay, so your patient is 5'8", okay, and weighs 180 pounds. I am asking you to calculate the body mass index, okay? So body mass index, our formula is kilograms over meters squared. Okay, so if we go down here, okay, so now you have an issue, right? Because I gave this to you in American, because we're so good at that. Okay, so first we have to figure out how much these are in our metrics, right? Because our formula is in metrics. Okay, so kilograms are first. Okay, remember 180 pounds. In order to find out how many kilograms that is, we're going to divide by 2.2. And we're going to get 81.8 kilos. Okay, everybody good with that? 180 pounds divided by 2.2 kilos. This is our weight. Okay, so when the time comes, we're going to put that here. Okay, now we have to figure out meters. Okay, so we have 5 feet 8 inches. Give myself a little more room here. Okay, so 5 feet times 12 inches, right? We know that that's 60 inches. And we add our 8 from here. We get 68 inches. Okay. We have to figure it out in centimeters, 2.54 centimeters. Okay. Oh, so sorry. Excuse me. Oh, excuse me. Okay. We have 68 inches times 2.54 centimeters, which gives us 172.72, which gives 172.7 cm. Okay. Remember, in order to get our meters, we're moving our decimal over 2 places, and we get 1.7 meters. Okay. So meters goes here. So we have we have kilograms, 81.8 kilograms divided by meters squared. So we have to take 1.7 and square it. And in order to square it with your simple calculator, you just multiply 1.7 by 1.7, so 81.8 divided by 1.7 times 1.7. And this equals 81.8 kilograms divided by 2.89. And the answer that you get is a 28%. Okay, everybody see how we got there? If you're confused by this, please schedule an appointment with me and we can sit down and talk with it. Okay? Okay. Our 1.82 meters. And we want to know how many feet. Okay, so remember, we got to go backwards with this. We have 1.82 meters. We're going to take it, we're going to move our decimal place over, so we get 182 centimeters. We're going to divide by 2.54 because we know that there's 2.54 centimeters in each inch, right? Okay, and this is 71.65 inches. Okay, what you can do here is, I know personally from all these other problems that we've worked out that 5 times 12 is 60. Okay, so this is 5 feet. If we did 6 times 12, we get 72 inches. Okay, so it's a little less than 6 feet. Okay, so what I would do is I would take and I would subtract the 60 inches. So we get 11.65 inches. So we have 5 feet. 11.65 inches. Excuse me. So basically, this patient is almost 6 feet tall, right? Okay. All right, this is a nice easy one. I love these easy ones. Okay, so if we have 240 milliliters, okay, this is the easy question. I hope you guys never miss this, okay? 1 cc equals 1 ml, okay? So 1 cc equals 1 ml. So 1 cc equals 1 ml. So if I have 240, let's do it this way. Let's make this X. This becomes 240 ml. So if this is 240, that's 1 and 1. This is 240, right? So 240 mLs equals 240 cc's. Okay, so if I tell you that you have 2.4 liters, okay, how many milliliters is that? You're going to move the decimal over 2 places. Okay, so that's 2400 ml equals 2400 cc's. Okay, this is just an extra problem here. Don't let it confuse you. Okay. All right, so everybody okay with that? Okay, so we have our, I'm sorry, this is very hard to do without you guys here because I don't know if you're getting it or not. So hopefully you'll let me know if you don't get it. Okay, so we have our 80 kilo patient. Okay, remember that how many kilos is a pound? Okay, there's 2.2 pounds. Whoops, how did that end up there? I don't know how that worked out. Okay, 2.2 pounds and a kilo, right? So if we have 80 kilos, we divide it by 2.2 pounds, or I'm sorry, oh, forgive me, bad, Amy. Okay, 80 kilos times 2.2, my bad, okay? So 80 times 2.2 gives us 176 pounds, okay? All right, so we have our 66 inches. In how many centimeters is that? We have 66 inches. We know that there's 2.54 centimeters in 1 inch, right? So we have 66 times 2.54 cm. And we get 167.64, which when we record it in the tenths, because this is less than 5, it goes down to 6. 167.6. Oh, I'm so sorry, guys. Kind of snotty this morning. All right. Okay, those are our math questions. Don't forget, please, email me. Sorry. Oh, boy, that's really impressive. Okay, with that. Okay, email me your answer to number 15, then you'll get credit for attendance. If you don't do it, you don't get attendance. Please figure out the answer yourself and don't copy your friends. Don't be that person. Okay, thanks, guys. Have a great day. Stay warm.